We really wanted to open it up for questions or comments. We have Sue as well as Tari and Patty Robertson are here as well. So any questions or comments from the audience? Yes. So that's a good question. So the lunchtime panel, we are going to have some experts of people who are working particularly with older patients, but I would open it up to Patty or to Tari. Any other comments? We've talked a lot about the need for durable power of attorney and healthcare forms and so forth. So you guys want to come up?
Hi. Well, I just think you have to realize that older lesbians are of a different generation and they're much less likely to come out. I had a patient who was like 82 who needed a DNC procedure because she had some bleeding in her uterus, and she was with another woman whom she introduced as her sister. And I got to know them over the next year or two, and finally they did come out to me. So they just felt safer presenting themselves as sisters, and so you're going to find that they're probably less out. Also, it's just now that we're looking at elder abuse and neglect in the community, and there's a story from San Francisco where a neighbor called the welfare or adult protective services because of some unusual behavior happening in the house next door. And basically, they went and investigated, and they found that there was a lot of barrels of urine around the house, and there were a lesbian couple living there, and one had dementia, and the other one was very controlling, and they didn't want to reach out to social services because they were afraid they were going to be institutionalized. And so just realized that they lived in an environment very different from the environment most of you are in terms of disclosure and being really afraid of government and social services. But there's such a lack of literature and studying older lesbians, except the social research that's gone on that's shown that isolation is a huge issue in this community. In both San Francisco and LA, it sounds like we're developing housing projects for elder LGBT, but they're very much in their infancy. The East Coast has done more work, I think, with SAGE, but I'm interested in what the other speakers think.
I really don't have much to add to that, but I would like to acknowledge that Hillary Meyer from SAGE is here, and they are the leaders on dealing with LGBTQ elders. So in addition to the folks that will be speaking on the panel, they can probably offer some more information.
There's a question back here as well.
Well, it's not a question, it's a comment that's happened to me. My wife and I, we've been together for 20 years. Last year, I have surgery for hysterectomy, and the first thing they told me that I have to take the pregnancy test before it, and I told her that there's no way I can get pregnant. And actually, they did 3 pregnancy tests before I actually have surgery, just to make sure I'm not pregnant. So it's kind of like a waste of money, and they not listen. So the second thing that happened to me, that I went to another doctor and, be with my partner. I told her that I have a partner for 20 years and all this thing. And she thought, we have to do HIV test on you. And that, it's like, and they're like, why? And they're like, well, because, we need to make sure of what? Because we both negative, so.
I'm so sorry. The health system really failed you all. But we do sometimes see the other side of that, where someone's had a hysterectomy and the pathology specimen shows there was an early pregnancy inside. So it's kind of defensive medicine. But, it shouldn't happen to you. And some dermatologists, before they give out some of the retinoid products, they'll make lesbians have pregnancy tests and actually make them be on birth control because they're worried about getting sued. So it's just very disrespectful of what happened to you. And also, I had a friend who left her gynecologist of like 25 years after her hysterectomy because she said something very insensitive about sexual practices and obviously didn't have any interest or knowledge about lesbian sexual practices. So these are the little things that just make huge differences to people. Thank you for sharing.
We have another question over here.
I just want to make one more comment about that, because as an example for the Accutane example, because I'm an internist, we do slightly different sorts of medicine. My daughter was treated with that medication, and it's actually a law that pregnancy tests be done. My daughter hadn't even started having her periods yet. So I think one of the issues for healthcare providers in general is sometimes you will be in a situation where legally or by protocol a pregnancy test is required. And part of that comes out of the fact that people often don't feel comfortable disclosing, as we were talking about, that they may have had sex with a man or frankly been abused or assaulted. So I think this is one of the most sensitive areas of how we as providers deal with that situation, where a woman who has told us, there's absolutely no way I could be pregnant. I'm in a relationship with a woman. I am not having sex with men. How do I approach that? That, well, if you want this acne medication, that's a requirement. They won't allow me to prescribe it without proof of that test. So, and again, with that, that's because it causes birth defects at a very high rate is why they've made that requirement. So I think that's something for us to all think about, and we're still working on. I've learned working through this group and talking it through that for some people, just being very clear, first of all, I hear you, I support you, I see why this is unreasonable, but then explaining, why that might be a requirement in a certain situation. So, and I'm interested for other people, if you've maybe been in that circumstance, what's worked for you, either as a provider or a patient.
Hi. I wanted to say one thing, and then that made me want to say another thing, so I'm going to say two things. So I think that that's the key, is for those of us who show up with so much fear, the idea of having just 30 to 45 more seconds of communication in that moment could have said, I certainly completely respect your relationship, and here's how I am going to make sure that you get all the tests and medications you need. Takes just a moment, but in our healthcare system, we're so not used to receiving that extra 30 seconds, and so I think we can strip away that fear simply by doing that and training folks. And I wanted to stress that there hasn't been a ton of talk about pediatrics, but I can't stress enough how there's so much problem in pediatrics with the competency around this kind of care. And the worst discrimination I've faced, my wife and I, has been around having babies and them being cared for in pediatrics. And so I think it's just really important that, to have a lactation consultant come in the room and say, well, where's daddy? Or and then my partner saying, well, I'm the mom. Well, no, you're not, because she looks at me and I birthed them, so you're the mom. Okay, start there. And then, but actually the pediatrician walking in the room and saying, how did you create your family? That's an amazing thing to hear for us. Like, how did you create your family? Who lives in your home? Those are open-ended questions that help so much, and they go so far. And so in pediatrics, I just think we feel so vulnerable with our children, even beyond the women's healthcare experience. So I don't know what work is being done to work with pediatricians, but I'm curious about that, because I think that's an enormous gap.
I do know that what we did at Children's Hospital, that I don't work there anymore, but a lot of the providers that I worked with continue to do trainings around the country, and I did do lots of trainings. So I think there's always work to do, but I think kind of what I try to get across in my trainings is that it's really just sharing with your colleagues that it's communication and it's respect and it's openness. And if you are really good at communicating and you're present and you're open-ended, it's about beyond sexual orientation, right? You're going to get information that's valuable about all kinds of things. Janet mentioned sexual assault or abuse, or someone using a drug that they don't want to admit that they're addicted to Vicodin that they're taking for something, whatever it is. If we go back to the basic core of openness, taking that extra moment, being caring and empathetic, and trying to figure out what's going on with them without putting the judgments or the quick, get to the next moment, that's going to go a very long way. So I know Children's actually is HEI. And they do go around the country and present. Is there a need for more? Absolutely. We have a question
Here's a question. How often are healthcare workers discriminated by their patients for being LGBT? So yes, that certainly does happen. And there have been some research on doctors who will not refer to other doctors because they are LGBT. I think it's complicated, and I think that we always give patients choice. So I'll never forget this one instance where I was just like an intern in the emergency room, and this 13-year-old really needed a pelvic exam because we really thought she had an ectopic, and her mother was walking outside the room saying, "This lesbian is going to make my daughter not a virgin because you're going to put her speculum in." And I'm going, "Oh my God, how'd you find out I was a lesbian?" But it wasn't personal. It was just, she was so freaked out. She was just thinking the worst thing she could say to try to protect her daughter, for which she thought was then going to ruin the rest of her life, because if she thought that if she had a speculum exam, it means she wasn't going to be a virgin and therefore she wasn't going to be able to get married. I mean, those are cultural belief systems. But certainly, I'm sure there are patients who don't come to see me because I'm a lesbian, and it's kind of a natural selection. But there is discrimination, but there's so much of a need for healthcare workers right now that I'm not aware of anyone who's been affected by volume. And frankly, if someone has such an issue for my being a lesbian physician that's going to interfere with their care, they shouldn't be seeing me. My partners will be happy to take care of them. So that's kind of my attitude. But I particularly feel really sad to hear your story about your pediatrician, because yes, there needs to be a lot of education. I don't know if there's an advocacy group in educating pediatricians. I think we're doing a really good job more with adolescents and helping pediatricians understand about coming out. I just did grand rounds with an adolescent pediatrician at Children's Oakland, and it went really well. But I think we even had a pediatrician in our faculty practice who said she would take care of children of LGBT parents, but she didn't believe this population should be having babies. And because the university has a non-discrimination statement, and we have an amendment in our Constitution about free speech, they couldn't do anything. It wasn't, they couldn't fire her based on poor performance, and the whole rest of the practice was totally embarrassed. She finally retired, and everybody breathed a sigh of relief. But it's complicated. You can do all the research you want about finding a inclusive, family-friendly pediatrician, but you're going to end up in the emergency room, or you're going to end up with one of their partners, and to have to explain yourself every time is just exhausting. And that's why providing longitudinal care for LGBT patients is really important, so they don't have to keep coming out all the time, especially like when they're pregnant. Some practice you have to see a different provider every fourth visit to get everyone on board by the time you deliver. But I think it's much better if you can provide choice of longitudinal care with someone you can develop a trust relationship with.
I want you to stay there. I'll answer this too, but I want you to go ahead. So this is another question from a card. It says, what's your advice for encouraging lesbian and bisexual women who have never gone in for a gynecological exam because of fear of being asked these questions or being treated harshly in the exam? What's your answer? You can start and I'll answer too. Well, I think because we have very different perspectives.
Right. Well, I think first of all, you need to make sure it's okay that your partner or your advocate is there with you in the exam room. I don't think many people have an issue, but we also should have some private time with patients and just for trust. But sometimes we do staged pelvic exams for someone who has a lot of fear, especially this condition called vaginismus, where the vagina just tightens up because you're so afraid. And sometimes we'll just do the talk part first and come back in a couple of weeks, see how you're doing. And sometimes we actually have to do them under general anesthesia for some people who are so afraid you actually can't do an adequate exam, because causing pain is going to increase the chance they're never going to come back. And so you have to individualize it, go to someone who has time. Like nurse practitioners often aren't as time pressured as physicians. And I think NPs and PAs, actually our lesbian and bisexual women patients often prefer to see them because they have more time for communication, they're more inclusive, they're not as judgmental. So I would also suggest starting with a mid-level.
So the Gay and Lesbian Medical Association, it's called, GLMA, has a resource list on their website where you can find LGBT-friendly providers. So what I might suggest for someone who's very afraid is, I think it's a great idea to bring in a support person with you. But before you even get to that, is to go through. A lot of HMOs and different healthcare systems now have different characteristics about a doctor, and they may have LGBT friendly as one of the characteristics that you can find, then I would recommend you call that practice and you ask them, or get your support system to do that for you and say, I'm a lesbian, or you'll get someone to do that for you. Is that something that you'll find out based on their answer. So you might want to do that work ahead of time because you feel afraid to go in, which I can understand. So one, I would say look for resources on the web through different places like GLMA or the specific HMO, or possibly call your Planned Parenthood, but that does not necessarily mean Planned Parenthood is all LGBT, like in Tennessee, or I'm not trying to discriminate, or Alabama, but you may try a community clinic, but I would suggest, to feel a little safer, call ahead after you've kind of done a little homework online and talk to them, whoever it is who answers the phone. And you'll also just get a sense in general, if you don't like how they're too busy and they don't want to answer your questions, well, is that a place you want to go, even if you weren't LGBT? So those would be my suggestions, along with bringing someone with you.
Hi, we have a question over here.
Oh, two microphones. Hi, Kathleen Young, Cal State University, Northridge, Public Health Programs, Health Policy Advocate. I'm making a plea to this audience post-election, if I may briefly. We're with the Titanic, and everybody's up at the dining room, I feel like, sipping, and we are going to be gutted in this country. And Madam Albright has made the statement, which was used against Hillary Clinton's campaign: there's a special place in hell for women that do not support other women. I'm begging you to support and uplift our young women, all of our women in positions of power, in positions of leadership, out in the streets. And I can't say enough that we have to mobilize. So I asked the panel, how do we mobilize? How do we mobilize our young women? And how do we get people out of the dining room as we're being gutted at the bottom of the ship? I thank you for your time.
I'm going to just say a couple things. There's a couple things. One is that all of you can do it by your practice. So you don't stop what you do when you're dealing with your clients and your patients. You be that role model and that person that's a safe place. And then you share that with your colleagues and say, that wasn't a big deal. I just had a trans patient, didn't take me extra time. I helped that person. So individual level, I'm kind of someone who lives a life of macro, micro. And when macro is in trouble, then I go down to the micro, and you're all the micro. And if you're a practitioner, right, you can change the perspective and the experience of each of your patients, and you can work with your colleagues. So then you could do a systems change. You start down here with your own clients and patients, and then you can start talking to your colleagues and maybe talking to your supervisor and bring us in for training, or just say, these things happen and it's all fine. It's just like dealing with somebody else. So that's one thing. Another thing is I think there's groups like Human Rights Campaign will be fighting very hard. GLMA, that I mentioned already, has already put out statements. If we're talking about LGBT, I mean, there's a lot wider things. There's women's health. There's all kinds of things that could happen. I mean, race. There's all kinds of things that might happen with the new administration. But if we're talking about lesbian and bisexual women's health, there's the feminist majority. There's Planned Parenthood, who do include LGBTQ health in what they're advocating for. And they do have programs for young women. Around, that's more the macro, right? That's more around activism and not staying silent, which is very different from being a professional and working within your clinics. And does that make so? They're very different avenues of advocacy for our patients. I know. Right. And and this is up to individuals here. They're here as professionals in the healthcare community. It's up to them as individuals if they want to get involved in that way. Believe me, that's the other hat I wear personally. But for us here, it's more about professionally, how can they impact? And that's very radical, to be honest with you. To be able to go into an institution and treat patients who are scared to death and are going to lose rights, to be able to be their beacon of safety, that's a big deal. And then to share that with their colleagues, that's quite radical, I think. Does that make sense to people? Like, you can be the people within your institution to not only be the safe harbor, but also to give confidence to your colleagues that it's okay. Nothing's going to happen. We're not losing, insurance reimbursement or whatever for just treating this person like every other patient. But yes, if you want to do something larger, that's, I think, separate. Yes. Patty wants to say something. Or do you want to just get another question?
Hi, my name is Tara Slavin. I'm with the Los Angeles LGBT Center, and I have a question sort of for the group as a whole. One of the things that I think has been really interesting is that there has been an increasing, I think, desire on the parts of healthcare systems and on the parts of corporations generally to say they're LGBT inclusive. And when we're thinking about these trainings, and I know I've personally been asked to train a lot of people, when we're thinking about it and we go out and we do this training or we give this, sort of certification, what about on the tail end when there are these negative experiences? And what is sort of that loop back process? And I just love to know what you all have been doing about how do we ensure that quality control piece? Because I think increasingly we're going to see more and more people wanting into it, but we know that these are very large institutions and there's a very wide variety of cultural appropriate levels.
I think Tari will answer for HRC's HEI because that's, there really aren't teeth, in it. There were about to be put teeth in it, but there's score. But to me, if you improve it 50%, that's amazing. Of course there's going to be, if you're now at very few people know how to talk to patients who are lesbian and bisexual women, and you increase it to half or a majority of your providers and your staff are feeling comfortable and have understanding and education that these are potential clients, these are potential patients, and I feel confident that I can navigate with them, to me that's a win. If we hear about individual issues, I think I'm going to let Tari answer that in terms of that's more policy and administration, et cetera.
Yes. So what I'd have to say to that is, the HEI does have some training requirements, but it's very minimal, and I will admit that. And we've tried to increase that. But when you're talking about a hospital that has 3,000 employees, we're not touching every single one of them. And it only takes one person to really make a bad experience. It's that one social worker who tells Janice Langman that she's not going to be recognized. It's that security guard who pulls the partner away from the bedside and refuses access. So it's individuals that are going to make the difference. So getting as many people trained and on board, and being there as staff to check the behavior of others, and not accepting it. If you see something happen, say something. Make sure that you're not just condoning bad behavior that is happening. There are the Corporate Equality Index has long been a scored system, and so for corporations that have do something egregious, there's a mechanism built into that to take away points because they are trying to do well. And the HEI this year has transitioned to becoming a scored system. So this is the first year when we release our new report in March that facilities will receive an actual score. And there is also a point deduction for systemic issues. Now, obviously, an individual act of discrimination is not necessarily something that we would take points away from, but if that individual act was then defended by the institution, or the institution changed their policies and practices that led to that individual act, then that is something that they'd lose credibility for. So that's something. And I actually had a question that I'm going to address about the HEI since I'm up here talking, which was, what would be the first steps for an organization to begin the HEI process, and what level of staff has to initiate the process? So any level of staff can initiate the process. We have literally had a medical student at one facility initiate the process, but you do have to get the higher-ups to buy in. So, I would say if this is something you're interested in and passionate about, see if you can find some allies. If you have an LGBT resource group, that's the first place to start. Start talking to people in the key areas that are going to have to implement some of this stuff. So human resources. Most of the folks that complete the surveys are either from human resources, sort of patient services, sometimes marketing. So it comes from a wide range of folks. But the first year that a facility participates in the HEI, the training requirement is actually for their executives. So they understand the policies and practices that we're looking at and we're talking about. So if you're going to fully complete the HEI and expect to score 100, you would need to get those executives on board because they're going to have to be taking a training. So anybody can initiate it. But really, it is best to work within, to have a larger group, to get the buy-in of the administration, and but we're happy to help you make that case to them that they should be participating.
I just want to make one comment with my healthcare administrator hat on, which I am at UCLA, and I thank you because it got my wheels turning about what are we doing about this. So two ideas are, for those of you that are in fairly large health systems, there's generally validated patient satisfaction surveys that are being done, and one way would be to advocate for a question, and again, maybe talking to people about some validated questions that could be included. The other thing is that large healthcare organizations now collect data on unsolicited patient complaints. Okay, so these are when the patient has felt so, aggrieved that they will actually go to all the effort of finding out who to complain to and to complain. Now, interestingly, the reason large healthcare organizations do that is that correlates very highly with their malpractice risk. But they're collecting it. So I think one of the things that we could do as advocates, which I had not even thought to do, was to talk to those people and say, can you sub-segment issues around this so that we can then bring that back to our committees to really understand what's going on. So that was very helpful. Thank you.
Actually, at UCSF, we have Press Ganey after outpatient visits, and recently there's been a question on there, did you feel your physician respected your sexual orientation? So it reminds me that I should actually try to follow up to see what the results are. So here's a question. Why are there higher rates of smoking, alcohol use, and depression among lesbians and bisexual women? Well, I'm not sure there's any research on that, but in general, it's felt that social anxiety when you're coming out is helped with alcohol, so it kind of numbs people up so they feel comfortable talking about themselves. And bars used to be the traditional gathering place. Hopefully communities have lots of sports teams now, although there's hesitation sometimes in joining a sports team because it's kind of like self-identifying as a lesbian when you look at in the book this chapter on exercise. I don't know about smoking, but it's we have this Dykes March on Saturday night before the Pride Parade, and I just want to go up to those young lesbians who are smoking and say, these are cancer sticks. What are you doing to your health? Because now we're seeing our 50 and 60-year-old lesbians with chronic pulmonary disease and lung cancer. And it's like, and we know that smoking cessation programs, they have one at Lyon Martin called The Last Drag. And it's effective as any smoking cessation program is, and also LGBT people are using online smoking cessation programs, and it's not the first time that you try to quit that you usually quit. It's the second, third, or fourth time. But I don't know why specifically there are higher rates. But I want to take a stab at that question that you brought up from the political point of view, because it was brought to me. I went to a mixer of students interested in OBGYN put on by my professional organization, the American Congress of OBGYN, and I was talking to some students and just talking about reproductive rights, and I got this email afterwards from the student who said, thank you so much for going, blah, blah, and we're so happy that someone's going to stand up still for reproductive rights. And I'm going, are you crazy? This is what we're about at UCSF and our department. And it's just being articulate as a role model, and all of you are role models who came here to speak up what you believe in, especially the younger people. They want to know that you've lived through the Reagan administration in California and in the United States. We made it. Yes, we couldn't submit grants with the word AIDS in the abstract. We've lived through the Bush administration. We've gained some rights during, not many. To me, now we have to protect the rights we've gained in the next 4 years. I mean, we need to put, I'm not sure how much progress we're going to make. But we all, you're leaders, you came here, you took time out of the office, you're interested in learning. go back and talk, okay? Communicate and inspire other people, and then figure out your own personal agenda for how you want your environment for your children and for your families and for yourselves and your partners, and work toward that on your own. There's a lot of creative stuff going on right now. But please don't lose heart. You know, we can do this. We have done it in incredibly repressive times. We just have to be really creative and techie, and for you all to be leaders. So that's what I've been reflecting on.